This is Karen with newclevelandradio.net, and it is time for our Mojo with Melinda Smith. And Melinda, you have a guest who is returning to our show. So,
Yes, I do, Karen, today. One of my friends, and she's got such an important company in what she does in the medical care for seniors and for other people who just need advocacy. So we wanted to bring her back so we can have more conversation. So welcome, Roberta Brofman. How are you?
I'm great. Thank you so much for the repeat invite. This is terrific. Thank you.
Well, and for those who may not have seen your original one, it was quite a while ago. Tell us a little bit about you and how you got into your business.
Great question. So I am a registered nurse. I have been for over 35 years. My background as a nurse is a little different. Most nurses end up going into one area of nursing and pretty much stay there. But I've pretty much worked the full spectrum of healthcare, starting in the intensive care units, where I gained a tremendous background from a clinical perspective. I've worked long-term care, skilled care, rehab, home care for about 15 years. I was the chief of strategy and program development for the Visiting Nurse Association. And then from a leadership perspective, I was a director of nursing and a vice president of clinical services, overseeing several nursing homes. So it kind of gives me a little different perspective. So you asked me how I got started in what I do. So the company is called 5-Star Clinical Solutions. And there's two services we provide at 5-Star. The first, which I started about 7 years ago, is dedicated to really improving the care that patients receive when they're hospitalized, when they're in rehab, when they're in long-term care or nursing home. And I use the many years of experience that I have working in these organizations and leading organizations, because quality is absolutely essential. Mm-hmm. And this begins with strong leadership and high standards of care. The second really was born out of a terrible situation that my husband went through. And we probably talked about that the last time, but he was scheduled for an overnight surgery, quote unquote. I stayed with him, and to make the long story very short, it turned into a complete nightmare of life-threatening complications. And when I brought my clinical concerns to the surgeon, he told me, quote, "Stop thinking and just be a wife." Well, it turned out after days of complications that I demanded he be transferred to the intensive care unit, and they immediately, without even touching him, they recognized that he was already in septic shock. He spent over a month in the intensive care unit, another month at home with me taking care of him. He had IVs, a PICC line, antibiotics, catheters, dressing changes, and of course, I took care of him. The moral of the story really is that had I not been there and didn't have the kind of expertise that I have and wasn't able to advocate for him, he truly would have died in that situation. So that's really what started the patient advocacy part, is that there's such a huge need out there. I joke that you can be Elon Musk and be absolutely brilliant and send rockets into space, but you don't necessarily understand the ins and outs and resources and the language of healthcare.
Yeah, they make it very difficult. You end up in the hospital. You don't have one consistent doctor. Everybody specializes, and then you have the floor doctor, and the floor doctor might not be there tomorrow, and then you have to relearn everything, and you don't know what they had other problems before they came in with whatever one they're in now.
Well, I joke, Melinda, that I don't know if you're old enough to remember Marcus Welby. Anybody remember Marcus Welby?
Yeah.
Show? Okay. So Marcus Welby was the guy who knew you. He knew you and your kids and your husband and, the whole family. And he birthed the babies and he did everything. Well, the great news today is that we have specialists that can do amazing things. We can take a baby out of utero, fix its heart, put it back in, deliver it months later. But nobody knows you anymore as a whole person. Mm-hmm. You go to your endocrinologist and your cardiologist, and maybe your primary care doctor knows you, but they don't know you as a whole person. And to your point, Melinda, we have something called hospitalists now. Mm-hmm. And I think it was born out of a nice idea, but it really doesn't work well. So a hospitalist is someone who is in charge of admitting the new patients, getting to know them. And so basically they get to know you for about 20 minutes. They look over your medical record, and then they're supposed to write orders and do whatever they need to do for your care. Well, they don't really know you as a whole human being. Mm-hmm. They might be looking at your cardiac issues or your broken leg or whatever. And then what happens when that hospitalist has to take a day off? they're entitled to a day off. Now a
Mhm.
new person has to learn all about you. And it just doesn't make much sense because you're kind of fragmented into all these different specialties.
Well, and you might be missing something important. I think I had talked to you before the show. I have a client who went in the hospital 3 times since August, but the first initial thing was a fall, and she broke her wrist badly. So she just got all the pins and everything taken out a couple of weeks ago, and she had another fall and something else. They took off her cast and never put it back on, and nobody even knew that she needed it.
Yeah.
If I had not been there and
Yep.
already known, that would have gone by the wayside. And who knows? They warned her to be very careful. It was a very bad break. She could end up back with pins.
Right.
This
Right.
should all be in her medical history.
Right. And,
No one read it.
everything's on electronic medical record, which is, okay, it's a pretty efficient system, but how does someone who's just met you, how are they supposed to go through this entire medical record and your whole medical history? And as we discussed before, if your client, you said, had a little bit of dementia. So she may not have recognized that that was something important. So thank goodness you were there. Someone was there to advocate for her to say, hey, by the way, she's supposed to have a cast on that arm and you removed it. Let's put it back on.
And she had to go through another orthopedic consult because they don't know when it was taken off. So they don't know if new damage occurred before they would get another cast, a brace to put back on.
Yeah. And guess what? That specialist, and I'm not throwing any of the doctors or anybody under the bus here. It's just the way healthcare works. But all those different specialists that come into your room and see you are going to be billing for that episode. So we wonder why healthcare costs are so high. That's one of the reasons, one of the many reasons.
Oh, absolutely. So how do you differentiate your patient advocacy services from other people who work in the senior field?
Well, that's a very good question. So there's many services that provide things like transitional care, such as placement or private duty aid services.
Like what I do.
Yes, exactly. And I think what you and I do complement one another. There are advocates who have worked as social workers, or there's also patients that I know that have had a bad experience and kind of educated themselves about how to help people. I think what sets me apart is that I have that extensive clinical knowledge and experience as a registered nurse and in public health. And I have many connections, such as yourself, Melinda, with vetted resources who can really provide the help that's needed. I work with a lot of elder law attorneys, with financial planners, private and skilled home care professionals, real estate professionals, and DME providers. Because honestly, as much knowledge as I have and experience as I have, I'm not a DME provider, but I have to find people who can do those kinds of things. With your business, for example, you can run to get groceries, to help with supplies, to be a companion, to go get prescriptions. I remember when I did home care years ago, I had a client who was discharged from the hospital. She was diabetic, and she had all these orders for how she's supposed to take her insulin. They taught her how to take her insulin. Well, guess what? She had no way to get to the to the pharmacy to get her insulin. It's like, what was anybody thinking when they discharged this woman? Did anybody ask her, how are you going to get your prescriptions? Now, today we have services that will deliver to you, but back then we didn't. So of course I went to the pharmacy, picked up her medication, showed her how to give her insulin, but that person would almost certainly have ended up back in the hospital, which is not a good situation.
Right. Well, this particular client has only limited family and they're busy. So that's where I filled in the gap. But you and I have had people together because obviously I'm not an RN. I don't have all those numbers, all those letters behind my name like you do. So there's things I don't know. And so you and I were able to help someone who was in long-term care as much as we could, because between the two of us, we handled different pieces of the puzzle.
Yeah. And, Melinda, to your point, the puzzle is so confusing. People ask me in your 30-second commercial, tell me what you do. And it's so challenging because it may be billing issues that people have. I mean, I've dealt with someone who went to the emergency room and it was a legitimate emergency. It was something, not to divulge the details, but it was something where if he had not gone, he would have been in a lot of trouble within a few days. So I advised him to go to the hospital. They treated him. They said, yes, you would have been in trouble had you not been here. Well, he gets a bill. They didn't code it as an emergency. So they told him he's responsible for the bill. And his insurance was only going to cover a very small portion of it. So we had to go through all kinds of hoops to try and figure out how they coded it, what happened, get the hospital to recode it. There's so many different things that healthcare is involved with, and insurance is, and coding and those kinds of things are one of them.
Well, and it needs to be coded properly.
Of course.
That's the challenge. Right?
And most of the time people don't look at their bill, especially if your insurance is covering, most of it, if not all of it, then it's like, okay, well, they're covering it. But what happens to all of our costs? It's just passed on to the rest of us when that occurs, right?
Right. Well, when they code it, they have 5 different areas, and you're not quite sure which one goes with which.
Yes, and I used to be a home care coder, so I kind of get all that kind of stuff.
See,
Absolutely.
that's why we complement each other. You do all those things.
Yeah, absolutely.
So tell me how a typical consultation works with your client. What do they expect when they're looking at your services?
Good question. So mostly I get referrals from people who are either like yourself and notice somebody who's having difficult. I begin with a call with the individual who has the concern. So sometimes that's a daughter, it's a son, it's a neighbor, it's a relative. Maybe it's a family member, and I listen very carefully to what their concerns are. And as I do, I'm starting in my own head to formulate what that individual plan of care is to meet their specific needs. There's not a one size fits all at all, because these are all individual human beings. Often that's with 5-Star Clinical. Sometimes it's with one of my colleagues like yourself, Melinda. And sometimes it's a combination of all of the above. And I share tentative plans as I listen to them and make sure that I've understood correctly what they need. So the next step would be for me to send them a HIPAA release if they want to go forward with our care, and an agreement form for their signature. So that enables me to talk with their physicians, with their care providers. Sometimes it's a person who's at home, and let's say mom has fallen a couple of times. She hasn't broken anything, but I'm a little concerned. She seems a little confused. She didn't have any. I came home for Christmas or Hanukkah, and there were no groceries, and she hadn't refilled her prescriptions. That's going to land her in the hospital, right? Mm-hmm. But I have to go back to work, and I have to go back to Vermont and my kids and my family. What can I do? So that's a perfect opportunity for me to be able to come in, to bring resources into that individual and to provide care and advocacy for them.
So when they come to you,
mm-hmm.
What you described a bunch of things you're looking for. Is it usually the kids that come to you and say, hey, mom or dad needs this help? Or do people come to you because they have nobody?
People who have no one that can advocate for them probably aren't going to get to me, because there's nobody who's going to tell them that there's somebody like me. I can't tell you how many times I hear people say when they hear what I do, oh my gosh, I could have used your help last year. My mom was in the hospital and this happened, that happened, or she was in a nursing home and it was terrible. And I'm not, again, throwing the nursing homes under the bus.
No, I know.
They're struggling, and I've worked in those facilities, and it's not an easy job. But some places are better than others, and sometimes you're not receiving the care that you need. So most of the time it's a colleague like yourself, or it's a son or a daughter who maybe has seen my website or heard some, a podcast like this, and calls me and says, hey, I don't know if you can help my dad or my mom, but this is what's going on. And I ask their permission to have their phone number, call them, listen to them, and we go forward from there.
Do you think that seniors that are by themselves are getting a little smarter about looking for help? Because I feel like they are. The calls that I've had for my business,
mm-hmm.
sometimes they're calling themselves because they realize they just can't do these different tasks.
Yes.
So, they get referred to me.
Yeah, it's a great question. I think that as all of us age, when you think about who's a senior today, seniors today, young seniors, I guess I'm going to call them, maybe the 50 somethings, are pretty technologically savvy. They can Google something, they can find something. There's also so many opportunities out in the community to go to area on aging. You and I are going to be part of, on the October 31st, we're going to be doing something at Beechwood City Hall, where we're going to be having a wellness fair for seniors. So that sort of thing gets out there in the community. People talk to one another. And yes, I think you're correct. They are much more savvy than they used to be. My grandmother was, I mean, first of all, technology didn't even exist back then, but my own mother, would have been able to do that kind of stuff. So as we all age, we're going to have to be more savvy about our own technology and how we help people as well.
Now, there's an organization through our called the Ethel Circle, which I've joined. And the interesting part is how many women have no concept of what they're going to do if something were to happen to them or their partner.
Yeah.
And I've been feeding them tons of information. And now you would think ARP would be out there providing information, that there are people like you. Most of them have no idea. And they don't know how to advocate for themselves anymore, because the comment is, the doctor doesn't listen. And I've been in that same situation myself, where I've had to say to the doctor, if you're not going to listen to me, I'm going someplace else. Now you have a choice.
Yeah.
If he doesn't want to listen, he's going to say goodbye. There's a store.
Yeah.
But most of us panic when that happens, because we don't want to go looking for another doctor.
Right. Well, you get used to somebody, but as I joke, you can get used to a telephone pole, but there are many options out there. And I want to say, in defense of the physicians and nurses and nurse practitioners out there, one of the things that occurred several years ago is that they kind of sold their souls to the devil. We have private equity firms now. We have hospitals that they said to these physicians and nurse practitioners, you know what? You don't want to mess around with billing and coding and overhead. We'll take over all of that stuff for you. Well, it sounds like a great thing. And then you can just be the nurse or the doctor, take care of your patients. That's what you went into this for. Well, the catch-22 here, the little string attached, was the fact that then they said you need to see X number of patients per day, and you can only spend 10 to 15 minutes per patient. So, if you've ever gone to your primary care doctor, if it's not concierge medicine or direct primary care, you get 15 minutes if you're lucky. And 9 times out of 10, you're saying, oh my gosh, I forgot to ask this question. Have you ever tried to call your doctor back? Yeah. And again, we're not throwing them under the bus, but it may be days before you get a call back. Then the whole cycle starts that you're worried. So you go to the urgent care. The urgent care sends you to the emergency department. The emergency department is backed up. They don't have beds in the hospital. So they board you in the emergency department. And you have a much higher risk of dying, believe it or not, in the emergency department if you are boarded there. Okay. So the whole cycle is a mess. And you're seeing more and more, the physicians are not happy with this either. That's not why they went into medicine, so that they could spend 10, 15 minutes per patient. They're starting concierge medicine practices, direct primary care practices, so that they can spend the true time that they need to with each patient. And, what do you need from your nurse or your doctor? You need to trust them. You just told me I'm supposed to have surgery. You just told me to go on this medication or these 3 different medications. I'm a little hesitant. I need to be able to implicitly trust you before I can listen and be compliant with what you're telling me to do.
Well, my own mother went into the hospital to have heart surgery. And when she went home at the end of the week, her medicines were changed. They didn't tell us. She gets her medicines delivered by Exact Care, so she gets a packet they changed everything. And all of a sudden they're saying, well, you have these prescriptions to pick up, but it's not in her pack.
Right.
And that's a whole nother fiasco. It takes a little bit to rotate into the pack. Right. And if they make a change, it's a month or so before you can do that.
Right.
But they made all the changes. They never checked with her regular cardiologist or regular internist, nothing. They just did it.
Yeah.
And didn't inform us.
Well, and she may have had issues while hospitalized that those medications made sense. But once she went home, maybe they didn't. I'll give you an example. I have a client who has some heart failure. He fell, he broke his hip. He went to the hospital, had surgery, went to rehab. Well, he was on Lasix, and I helped pour his medications in a pill box. He was on Lasix, a diuretic, 3 days a week. He came home on daily. Okay, so all right, well, maybe he needed that. Well, after a few weeks, it was pretty clear that from my visits that he was dehydrated. So I called the primary physician and I said, we need to get some labs, see if he's dehydrated. I think we need to back off on his Lasix, his diuretic. Never got a call back. Never got a call back from them. And he's a good doc. He's a good physician, but I never got a call back. So I'm in this conundrum of I can't let this man become dehydrated, and yet I don't have an order to change this. So I brought in a primary care physician to the home to be able to change this. So, that's one of the advantages to having me come in. And I generally see my patients monthly. I do a physical exam, a home safety evaluation, a cognitive assessment at least quarterly. And, I was able to pick up on the fact that he was getting dehydrated. He was becoming more confused and he could have fallen again. So, again, in the hospital setting, in the rehab setting, perhaps that was an appropriate dose of medication. But when he got home, he did not need that.
Well, no one was overviewing what his life was going to be when he went back.
Yes.
Now, between my sister and I, we're both her advocate.
Yeah.
And we looked at the meds and we're like, why does she need this?
Mm-hmm.
Now, we did go through sending the emails. That's really what they want you to do. Go through their My Chart, send it in an email, wait up to 48 hours to get a response. But between the two of us, we advocate for her pretty strongly.
Yep. Good for you.
So we managed to we're like, why is it here? Well, this is what they did in the hospital. Okay, why is it here?
Yeah.
And they didn't have a good answer. So we got rid of it. But not people are afraid to do that. People don't have somebody advocating for them. So that's a huge obstacle, don't you think?
Absolutely.
Here today.
Well, and the other thing that I really love about being in someone's home and when I did home care for many years is you see that individual in their own element. Mm-hmm. So, okay, we did physical therapy and you know how they have the little 3-4 steps that you climb up and climb down. Okay, now you go into their home. They've got a bunch of throw rugs that slide all over the place. The staircase is filled with shoes and newspapers, and it's a big fall hazard. They have no first floor bedroom or bathroom. So,
what are they supposed to do?
Yes. And or they have a family member, maybe it's a husband or a wife, but they have severe dementia and they have to care for that person. But nobody bothered finding out about all of this. And then we're so surprised that they end up back in the hospital, right? It makes no sense.
They want you out as soon as possible too. You know,
and
they're not really looking. We can't discharge you unsafely, but we can't keep you here. So now you got to find a place you have to go to.
Yep. And you can understand the push and the pull. You've got a physician and a nurse who is told, I need that bed. I've got the emergency room again, we're boarding people. I need that bed to get somebody in. This person's stable, get them out. Right. But again, I can't tell you how many times I get phone calls from people who say, oh my gosh, my dad is in rehab and they told me he has to leave, or he's in the hospital and they told me he has to leave. I can't take care of him. I'm working. Mm-hmm. I have kids. And he's alone. What am I going to do? That's very common. And, we start the process of talking to the discharge planner and saying, okay, what have you set up? Do you have home care coming in? Is he safe at home? And then, I can go in and help them and get the resources that they need.
So I have a question for you. 9 years ago, I broke my femur. I went right from the hospital to rehab because our bedrooms are upstairs. My husband works full time. Mm-hmm. But before I was released, they actually brought me back to the house and had me walk through the house with them.
Nice. Teach
me how to get up the stairs. They told us what we needed to change. So I thought this was routine, but what you're saying is this is not routine at all.
No, I'd love to know where that was if you want to
Me
say.
Me too.
Yeah, no, that's fantastic. And that's what should happen. But, does the hospital have the resources to be able to do that? Now, I know when I worked in home care, we used to send an occupational therapist out to the home on the initial visit to say, what kind of safety DME, durable medical equipment do you need in the home before you can get there? Maybe I need a hospital bed. Maybe I need one of those things that can transport me up the stairs in a chair, a motorized chair. Maybe I need grab bars. what do I need to keep me safe? And I think it would be a smart investment for the hospitals and the rehabs, because they don't want you coming back for the same diagnosis. They don't. They're actually fined for that.
Mm-hmm.
So it makes smart sense, I think, to invest and have a person that actually does, or people who actually go out and do that. But that was
It's
brilliant.
interesting. You don't get any, at least my experience, Karen obviously had a different one, but
Mhm.
usually they send you home. You're going to have home PTOT at home,
Right.
but it takes a week or more. It took 2 weeks to get my mother set up. So, and she was at home. Now we have a system where we have cameras, and we
Mhm.
had an aide coming in that we paid for. Well, my sister paid for the first 4 hours of the day to make sure
Mhm.
she's up and got her medicine, because then either she or myself could go if we really had to.
Right.
But 2 weeks before you set that up. And then you got to get
Well,
on rotation, and they only come once a week. So
yeah.
an RN came once a week, PT once a week, OT once a week.
Well, and you bring up an excellent point, Melinda. People don't know what the regulations are and what they're entitled to and what their rights are. So when you are discharged and they tell you that home care is coming out, home care is required by regulation to make contact with you within 24 hours and to come out to visit within 48 hours.
Yeah, that didn't happen.
I understand that. So there are different, some of them are struggling with staffing, but that's not an excuse. And they will be cited for that by the state and by Joint Commission, because they are required to come out within 48 hours. Generally speaking, it's a registered nurse that comes out to what we call open the case or start the care.
Mm-hmm.
And then the physician has to order, or the nurse practitioner has to order nursing, PT, OT, and aid, whatever. And then they set their visit frequency. Generally, they'll come out, the nurse might come out a couple times a week for the beginning, and it doesn't go on forever. It's usually a 60-day cycle. And then they decide whether or not you're making progress. If you are, they can recertify you. But it is a requirement that they make contact within 24 hours and come out in 48.
Oh,
And
that's
again,
interesting because
people don't know that. People don't know
right.
that. And unless you've worked in it, you probably don't know. There are actually 800 pages of regulations in long-term care. I mean, knowing all of those is a tremendous skill set. And then they
Right.
change them. And then they change them. So
Right.
you really, and that's part of what I do as a clinical consultant in nursing homes and hospitals, is help them to achieve that 5-star rating and get through those state survey processes.
I
So,
think the hard part is, let's requirements aside, once they get there, like I said, they come once a week. They're not
Mhm.
there every day. So going
Right.
to rehab, you hopefully have every day PT, OT. Home, you do not.
No.
And they're sending you home. You're by yourself.
Mhm.
What happened? And maybe you have the beginnings of dementia. You may not remember to let them in. They
Mhm.
change, they don't come the same time every week, right? So they alter it, they make a phone call, and
Yeah.
they just show up.
Yeah.
And there are some seniors, the ones that have the beginning of dementia, usually if they're full dementia, I think they'd be somewhere like in a facility, memory care. But you've all seen the seniors with the beginning stages of it. And it's just enough that they don't remember the appointments. They don't remember to allow people in.
Right.
And then they might say to you, oh, yeah, they came. No, they didn't, but
Yeah.
they think they did.
Yeah.
So
Yeah.
I think that's a huge obstacle in healthcare. I mean, how do you take care of these people if they have nobody?
Yeah. Well, I mean, the first thing you have to do is take a look at their circumstances. And I tell people all the time that when safety becomes a serious concern, it's time to look for placement.
Mhm.
I joke with my husband to stop giving money away, because I don't know who's going to take care of us in our old age. I don't know if our 3 boys are interested. Maybe they will. They're good guys. But if you have financial resources to bring 24/7 caregivers in, you're golden. You're good. And
Yeah.
we can find some good folks to come out to you, like you, Melinda, to help out. If you cannot do that, then we start looking at, what will your insurance cover? Do you have long-term care insurance? Will that help you to cover some things? That's a great option. If that's not the case, then one of the things we start looking at is, even if you're okay right now in your home, I tell people all the time, get on a waiting list. Get on a waiting list with where you know that the care is pretty good, rather than waiting till you have the emergent situation and now we have to place you and there's no beds at the good places or the decent places. Now you have to go wherever we put you. That's not good. And on a waiting list, if your name comes up and you really don't want to go, you're not ready, it's fine. Just say, hey, I'm
Right.
not ready, put my name down on the list, go to the next person. Not a
Right.
problem. Because I think people get very threatened with the idea that, you're going to put me in a home. Oh my God, I don't want to go. And there's a lot of things to balance. I have a client who's in her 90s. She lives past Orwell. It's about an hour and 15 minutes away. But she's just delightful. And she lives alone and she's stubborn as can be and she's a sweetheart. Uh, and she's on a waiting list, but she is adamant that she's going to stay home by herself and alone. And the other thing that I talked to her about is loneliness is not good. It's not good for
No.
you.
It adds to the dementia too.
Exactly, exactly. And depression. And depression is rampant in the elderly. So, what does she do all day? Watch TV, play with puzzles, she gets her meals on wheels. She has family that visits her periodically, but she's adamant she's not going anywhere. We do have her on a wait list. And she's very careful and she's very safe and she has help that comes in periodically. But I worry about the loneliness factor. Another thing that I see that's really common is that you'll have spouses and everything seems pretty copacetic. And then one spouse passes away. And all of a sudden the family starts going, I never noticed mom's really confused all of a sudden. I don't understand. She wasn't confused before. I don't know if she's just depressed. A lot of times what I see is that and I am a certified dementia practitioner, the one spouse will cover for the other one. Okay, so you don't notice it as much because the husband fills in for the blanks that the wife couldn't figure out. Oh yeah, it's at 2:00, honey. Don't you
Right.
forget. Remember, we went there yesterday. That was yesterday. We went to the doctor. It wasn't last year. And you kind of get this hint, but they cover for one another. And then all of a sudden, when the one spouse who covers for the other is gone, all of a sudden these issues appear. So
Right.
I can't stress enough how important it is. We are all individuals. One size doesn't fit all. There's lots of resources out there, but you really have to individualize the care.
When you
So,
talk about facilities, the sad part is facilities are getting a really bad rap.
Yeah.
Either they're very, very expensive, never going to be able to afford it,
Yep.
or, I'm going to be just a number there. And I don't want that to happen. I know when my mother went into independent living, they had independent, then assisted, and then nursing.
Mm-hmm.
And she fought it for about 6 months. And we finally said to her, you either can come live with one of us,
Mm-hmm.
or you can stay here, have your own apartment, and you already have friends who are living there.
Yeah.
And she went kicking and screaming, liked it for a while, but after a while, the care was not as good as it had been when she first moved in.
Yep.
And she kept complaining about it.
Yep.
And we just didn't have a choice,
right.
which was very sad for all of us.
Yeah, well, you could transfer her. And one of the things I tell people all the time too is I will recommend places, but I can't give you any guarantees about what's going to happen. Your call light might not get answered, might get answered like this, and it might not get answered for an hour. I can't predict. Some places have better reputations than others. But to your point, a lot of these facilities change hands.
Mhm.
So all of a
Wow.
sudden they're sold, especially these privately owned facilities, they're for profits and they're sold to another company. The company oftentimes comes in and just guts everything. Everybody's gone. They bring in their own people. And that might be a good thing, but sometimes it's not a good thing. Plus the fact that the residents have to get used to somebody new all over again. Gee, that nurse I really loved is gone. That aide that was so wonderful to me is gone. And sometimes it's also turnover. So the staff turnover, even if the facility doesn't turn over as far as ownership, the staff turns over frequently. And again, I can see both sides of this coin. It's a very hard job to do.
It is.
Try being an aide for a day. I mean, God bless them. And it used to be that we had kind of middle-aged women who loved people and loved the elderly, and this was their calling and their passion. And there still are some that do that. I have close
Mhm.
friends that I worked with who are excellent, but not all the time. And the other issue is it's expensive. So for
Very.
the facilities to hire more people to service the needs of all the residents is challenging. And I don't know if you're aware of this, but CMS or Medicare Medicaid Services was they're trying to pass a law that you have to have mandated amounts of nurses, RNs, and aides per resident. And it sounds on its surface like a wonderful idea. I mean, shouldn't we love the elderly and take care of them? The problem is that they don't have the money. They don't have the financial wherewithal to do this. So my concern, and I just posted something on LinkedIn today, is, and there's a lawsuit actually going on that a lot of these groups have gotten together and are suing the CMS. The problem is, what if these folks can't do this and these nursing homes are fined and they're shut down? Where are people going to
Place to
go for
go.
care? Where are they going to go? They're going to go home, and that's fine if you go home. Like you said, your mom could have gone home with you, but then you take people out of the workforce.
Mhm.
They're not earning the income they did. They don't have the disposable income to purchase things. Um, so what happens to the economy because of it? So there's a lot of it snowballs. It snowballs.
Well,
So there's
you
go
have a
ahead.
sandwich generation there, right? They may be taking care of their own kids at home
Yep,
and mom or dad, and
yep,
maybe they're running back and forth, and that's not healthy for the caregiver, the
yep,
child of the person,
yeah,
for their grandchildren, just for life in general. And you really do need to be on them. I mean, when my mother was in rehab, we were there every single day
yeah.
to
That's
make
smart.
sure she got her shower, to make sure that,
Mhm.
she was changed and clean clothes. And even with putting her in a decent facility, it was a lot of work. And
Yep,
there's two of us.
yep, yep. Yeah. Can you imagine if you have no one, or you have one person who lives out of state and they're just calling to find out how mom is? And it's a fine line you have to walk too. I'm sure you do, Melinda. Is that I've been that nurse trying to pass 25 meds to 50 people, and some daughter is in your ear screaming at you for something that may not have even happened. But you have to understand their anxiety levels very high.
Yeah.
They love this person. This person is deteriorating in front of their eyes. They're seeing that they didn't get the call light answered, or they're sitting in something that they shouldn't be sitting in, and they don't know how long this has happened. But
Mhm.
you have to be compassionate enough to deal with their concerns and understand that nurse. And I've interviewed some nurses who have come from other facilities where they had 100 patients a
Right.
shift. What? And some of these patients, residents, are on 20 meds apiece. And don't dare make a mistake, and don't you dare be late with any of those meds, because the state will come in and cite you.
Well,
So
and there's
I
only so
get
much you can do.
exactly, and I get how challenging it is for the staff and how difficult it is for the resident and for the family member to see their loved one, really deteriorating, and recognizing cognitively that something's not right and this isn't good. And how do you deal with that in your heart and in your soul? And
Well,
how does
and
a nurse help that?
most of the families aren't going to go in with your expertise or my expertise, less than yours. But I know to be that advocate. I know to open my mouth in the hospital, in the rehab.
Right, right,
And, older people are like, oh no, don't say anything. They're going to be bad. They're going to be mad at me. They're
yeah,
going to not give me my dessert. They won't
right,
take me to the what.
yep,
But you can't listen to that,
no,
because if you want their care to be the best care that you can manage, you have to be there. You have to help, or
right,
have somebody like you, which is what you do, right?
right. And to your point, there's a way to speak with the staff
Hmm.
to get what you want. If somebody's coming up to you and screaming at you,
It's not going to get you anywhere.
you have to be pretty chill and together as the caregiver to just take that and not take it personally, and just deal with it and respond, and to recognize where they're coming from. But there's a way to say what you need to say, that mom didn't get X, Y, and Z. That I'm sure, Melinda, you're capable of doing. But again, that's part of advocacy, is how you
Mhm.
ask the question, how you bring something to people's attention, and even your timing. That
Right.
nurse is in the middle of a mess.
Or a
You got
shift
cardiac,
change.
well, you got a cardiac arrest going on in room 2, and mom's in room 4, and she didn't get her call light answered. Well, maybe there's a reason, you know.
Mhm.
And I'm not saying that's always the case, but you have to look at the circumstances, and you also have to have, some understanding of where that other person is at as well.
Well, I think also understanding that the staff, if you understand that the staff is stressed, I always take the time to say thank you. Thank
Yes.
you for doing this because they don't hear that very frequently from residents or residents' families. That's
Yep.
for sure.
Yep. I always, always, always thank the staff. And even when I'm calling on behalf of one of my clients to talk to like a discharge planner, or I speak to the nursing staff or the aid staff, I always say, thank you for what you do. Thank you for what you
Yeah,
do. I know how hard a job this is. And thank you for what
absolutely.
you do. Yeah, that's
So that
great.
I think so. Other than we talked about a lot of things today, and I'm hoping I know that they were basically stories for people,
Uh-huh.
but they need to know they're not alone. They can find someone like you, like me, or we can direct them to somebody who could help them.
Yes.
Um, they're not alone. I mean, you're an
No.
RN. Look what happened with your husband.
Yes. Yes. And
It
thank
can
God I
happen
was
to
there.
anybody.
I mean, this guy was a runner before he went in. And when he got home, I have video of my kids helping him to walk up the stairs, couldn't make it up the stairs. Thank God he recovered. He
Right.
was more than full time, but still, really, really tough situation.
So, a couple quick questions. What are your goals for Five Star Clinical in the future? How do you see it changing?
Yeah, good questions. Good questions. I would say that, let me just wrote a couple notes. So as far as goals are concerned, it's funny. I asked somebody on what was it, on LinkedIn, had an artificial intelligence question to ask, and I thought this was really interesting. And the question was, from all your interactions with AI, what is the one thing you can tell me about yourself that I don't know about myself? So I'm going to read you the answer it gave me. And so the one thing that stands out from our interactions is your clinical inclination to blend technology with human care. So that would be one of my goals.
Mhm.
And from exploring virtual reality and hospice care to creating a patient advocacy business, you're driven by a desire to merge innovation with empathy. So I thought that was really interesting. Um,
Yeah,
so trying to make sure that our technology, I mean, technology is great. When we went through COVID, that dirty word, it was terrific to have a virtual visit with your doctor.
right,
That was fantastic because otherwise you were in trouble. Or to virtually visit with your loved one who was in a nursing
right.
home, which that don't even get me started with that mess. So how do we make sure that we don't create a more impersonal situation than we already have with your 10-minute visits? Now I get a 10-minute visit on Zoom call, really? I think that we also need to look at how to treat people as a whole person, not as a broken up piece of parts, excuse me, pieces parts. I've seen more and more people becoming advocates. It's interesting when I started this, and the patient advocacy piece I started, I think it was about 5 years ago. And when I first started, I didn't see anybody else doing this. I saw navigators, people that
Mhm.
were helping people transition over to assisted living and finding placement, but I didn't see anybody actually being advocates. But there is a huge need out there. So I was working, and I've created a program, a class, a course that people can take. And I'm putting that online so that people can become advocates and train to be advocates. So I really think that that would be very, very important because, again, like you say, Melinda, you may have had an experience that helped you to figure out what you should or shouldn't do. But sometimes it's too late if you don't
Right.
know what to do. So that's what I preach, and that's what I'd like to go do forward
In the
using that
future.
technology.
So, if you're putting out there a course that helps somebody become a patient advocate, um, what advice would you give them besides taking your course or a course that somebody else might offer?
That's a good question too. Um, I would say that look at your strengths. So what are the strengths that you have as an advocate? You know, you have to be, if you're going to be a clinical advocate, as I am, you really need to have a lot of experience and knowledge in the clinical setting. Determine what you're best at. That would be my first advice. What are you really good at? Are you good at talking with people? Are you good at interacting? Are you good at, maybe you're good at and actually I talked to somebody who wanted to do this. She was a CPA, an accountant, and she just was tired of being an accountant. And she spoke with me about wanting to become an advocate. So that's what she's doing. But she looks from the billing perspective and the insurance perspective to figure out how to help people. So again, capitalize on your strengths. You know, starting a business is not that challenging. However, it's only the beginning. The biggest part to me is running the business and figuring out how to market yourself. And Melinda, you're excellent at that. You can't really put a billboard out there, on 271 that says, "Hey, call Roberta. She's a patient advocate." What the heck is that? Like I say, I struggle with my 30-second commercial because there's so many things that an advocate can do to help you. So again, establish trust in the community. I think one of the great things, if you're going to do this, is networking. So Melinda, you and I are in many networking groups together. Yeah. And that's really important. Look at where the people who have the need are. So working with elder law attorneys is helpful for me. Working with financial planners is helpful because they often see people who they're investing, they are ready to retire, and now they're starting to have health issues. Where do they turn? So I get plenty of referrals from them and also from elder law, financial planners and elder law attorneys. So
the one thing that I would like to leave listeners with is if you feel everything's cost prohibitive, because I think a lot of people are worried about that, hiring home care, it doesn't have to be that way. And certainly if you couldn't take care of somebody, you would refer them.
100%.
Somebody who could.
And there are times when I've received referrals from people. I mean, obviously this is business, so of course I need to keep it as a business. But there are times when I've gotten hardship cases, charitable cases, where somebody is Medicaid and they're having a real struggle. And of course I've helped them, of course I have. But yeah, it's really difficult, especially if you're financially strapped. You have to be very careful too, if you're going into a nursing home and you're on Medicare. Be really careful that you select that nursing home that has either continuous care or will not, quote unquote, throw you out if you transition to Medicaid. People don't realize that. So you're going to do what's called a spend down, and they're going to take your assets unless you put them in some kind of a trust fund that isn't touchable and have done that like 5 years before. They're going to take your assets. I have a client right now her sister is going to sell her home. She had a stroke, unfortunately. The sister's selling her home, her car, her assets, getting her bank account ready. And I said to them, if you want to stay where she is right now, that's fine. It's not a bad place. But you have to realize, if not, start moving now and go to a place that will keep you if and when you transition to Medicaid.
Right.
Because a lot of the places that take Medicaid are not that good.
Not great.
Yeah,
well,
not
I mean, having the money, you mentioned long-term care insurance earlier. Most people never even knew about that. So younger people, that's our advice. I'm sure it's your advice too. You can put that in your budget because it's important. The one thing that I was able to do is I haven't needed to use it, but I have a whole life policy.
Smart. Yeah.
And I did that because in the future, what if I need assistance? I can borrow against that.
Yeah.
For me, that was the only option. There's a point where you've had too many illnesses and age. They don't do long-term care.
Yeah.
You can't sign up for it. So what are the options? That's it.
Yes, you're 100% correct. I have a client right now who hired me because her husband has long-term care insurance. She paid over $14,000 for aides to come in to help him. And now she's having difficulty because she applied and there's so much paperwork, she can't figure out how to do all the paperwork. So she
Right.
brought me in to help her to facilitate getting this claim started and completed. And she paid me up front, and I was like, most people pay me on a retainer. And I was like, oh, I don't, that's probably too much. And I would return the retainer if it was unused. And she looked at me and she goes, honey, I'm telling you, it's going to take more than that. And by God, was she right? I mean, ridiculous amounts of calls to the insurance company and forms to fill out, and filing those forms,
And they change.
Yes, yes. So we finally got everything paid for, but I mean, she was not well herself. And she's like, I can't do this anymore. I need somebody to help me.
Mhm.
So yes, long-term care insurance is fantastic. She'll be reimbursed for all of that. And then for the care that he receives, while he's home.
While he's there.
Yeah. Mhm.
So if somebody wants to reach out to you, because
Mhm.
45 minutes has flown by in this conversation, tell us how they can reach out to you.
So they can go on my website, which is fivestarclinical.com. It's the word five, not the number five. So FIVE, fivestarclinical.com. And there is a place you can click to get in touch with me. You can also reach out to me directly by calling 216-513-9622. And I will actually answer your call and I usually spend a good 45 minutes to an hour with each client, understanding what their needs are before we even get started. So
And you're on LinkedIn as well, correct?
on LinkedIn, yes, yes.
Well, if anybody lives in the Cleveland area, she mentioned it earlier, there is a Halloween healthcare event at the Beechwood Rec in Ohio, and it's from 10 to 2. So if she'll be speaking, she'll also have her table there. So if you want to ask her specific questions, that's the time to go.
Perfect. Yeah,
So,
looking forward to it. And a costume. We're doing costumes and lunches too for people too. So
free lunch for the
that's
first 150 people and the
costume
costumes.
contest.
So the
Mhm.
costume contest.
Yeah,
So
should be great.
they
Yeah,
need to do
I
their own
love
trick or
our
treating.
Yeah, I love our networking group because we call it networking with the heart, and the reason for that is that we raise funds for different groups, such as
Different nonprofits.
bank and nonprofits, right? So
And Roberta does a lot of our education. So
yes, yes,
you
yeah,
can tell she knows her stuff.
yeah. Thanks, Melinda. You do too.
Well, thank you for
Thanks.
being on today.
Thank
I really appreciate it.
My pleasure.
And if something new pops up, we're going to have you back again.
I would love that. I
Thank
appreciate
you.
it. It's an honor. Thank you so much. Have a good rest of your evening, guys.
You too. Bye-bye now.
Bye.
Bye.